So good morning, everybody. Thank you for the invitation, and it's my difficult task in an audience full of people who really understand mathematics to tell you something about the anesthetic-drug interactions and the mathematical models being the basis of drug interaction modeling. And there are two following lectures who will illustrate how these interaction models can be used. Now, first of all, I have to acknowledge also my right hand and very good friend Hugo Verreken, who helped me a lot in the preparation of this talk, and also the other team members. We have in our university a very nice group of people, and we have an international collaboration on these anesthetic drug interaction models. It's not only our own group, but we collaborate very closely with Martin Lugingbühl, who is present here, and with Bjorn Hayes from Ghent University. Formerly, we also had two other good friends. Now they left the team, unfortunately, Thomas Buer and Peter Schumacher. And we have a very close collaboration, and that's also my conflict of interest that I have to declare in this talk, with the people from the R&D group from Draeger Medical, Jürgen Menegel, Wilfried Buschke, and Christian Ulke. Some of them are also present in the room. They not only provide the money, but they also provide part of the brains of this group, and that's, of course, very nice. When we talk about interactions in anesthesia, ladies and gentlemen, we have to talk about two things. We have to talk about pharmacokinetic interactions. We all know that this means how drug A affects volume of distribution or clearance of another drug that you give. Next to this, we have to talk about pharmacodynamic interactions. That means how does one drug affect the clinical effect of another drug. Now today, I will only tell you about pharmacodynamic interactions. Honestly, I think also pharmacokinetic interactions will end up or result in pharmacodynamic interactions. So let's focus for today on pharmacodynamic interactions. First, we need data. If we want to describe the interaction of two or more drugs, you need to do the right studies. And that's not so easy as you could think of. When we talk about interactions in anesthesia, we talk about, you can study interactions until you retire. In fact, it's a very good topic for your career, because every drug that you combine with another drug will cause some interactions, and you can study that. But in anesthesia, we focus on the interaction about hypnotics to opiates, hypnotics with other hypnotics, and multiple drug interactions, for example, as I told you here, benzodiazepines with propofols and opiates. But you can imagine that you could also study the interaction of two anticoagulants, of two whatever, neuromuscular blocking agents, of aspirin and paracetamol. You could think of anything. For this talk, as the systems that are commercially available now, Smart Pilot View and NG Navigator, are focused on these anesthetic interactions of opiates and hypnotics, I will only describe the interactions and the underlying models that are used to study the interactions of these drugs. Now, there are some effects of interest when you study drug interactions of opiates and hypnotics. And there are, I think, two big categories of interesting effects to look at. First of all, you have the Dichotomous datasets, which are a kind of a binary situation, describing a binary situation, a yes or no. For example, the response to a verbal, tactile, or a painful stimulus. It's yes, the patient is responding, or no, the patient is not responding to a stimulus. For example, calling your name, or a tactile stimulus, or a painful stimulus. It might also be movement, it might also be a hemodynamic response in a result to a painful stimulus, cortical arousal, or other things. You could do a logistic regression of these dichotomous data, which gives you then the answer to the probability of a response in the population. For example, 50%, and much more interesting for anesthesiologists, 95% or even 99% of the population will not respond to a certain stimulus at a specific combination or concentrations of two or more drugs. For example, the MAC is one of these examples. Next to these dichotomous data sets, we also have now the possibility to study continuous quantification of drug effect. And I think the two big categories in the drugs that we are focusing on are, of course, the hemodynamic measurements. That's a continuous one that we can do in ROR. And the cortical, e.g., or auditory evoked potential derived indices as a reflection of the cerebral hypnotic effect. So two categories of data sets of data we can collect in patients or volunteers when we study these drug interactions. Now, another question is, are we studying drug interactions in steady state or non-steady state? I think it's much more easy and it makes much more sense to study drug combinations when they are in steady state or at least at pseudo-steady state, and to refer to John's talk, when the effect site concentrations have come to a stable situation. Now, if for one or other reasons your clinical situation during your study is a non-steady state condition, you could use pharmacokinetic dynamic modeling to calculate what the effect site concentration is at that moment if your drug is not in steady state, and that can be used to model your data much more accurately. We know that there is simulation software available to model effect site concentrations using these PK/PD models, and this can be used both for inhaled anesthetics and for intravenous anesthetics. At least you should take care of the hysteresis between plasma and effect site when you study drug interactions, and some examples in the literature show that this was not always the case when people publish their data, and then they have to be corrected. Now, you need data, and of course you need also mathematical models to fit the interaction data. This is very well known, I guess, to all of you. This is the classical isobolographic representation of interaction of two drugs. We all know that if the combination of two drugs doesn't add any more effect to the combination of effect, this is called additivity. If there is more effect, then you have a synergy. If the combination of two drugs produce less effect than if you would have given an equipotent combination of these drugs or these drugs alone, then you will have a infra-additivity. Many methods have been proposed to show these isobolographic approaches. You can draw it by hand. I will show you an example. If you have the combination of two drugs and you plot that combined effect just on a graph, you can draw a line through it. I think nowadays we have more statistical rigorous methods to help you with that. These are the historical references that are describing these methods of the isobolographic approach. I think one of the milestone papers is the paper from Greco and co-workers from '95. You need one holiday to spend reading this paper because it's 55 pages of highly mathematically oriented material. So please take your time. It's not something you do when you're on call and you have 30 minutes free. Greco made a statement in this paper that it is possible to have a rigorous statistic approach to show, to study drug interactions. And I think this is one of the first interaction models that is available in the literature. Now, this is like a drawing by hand example, or a little bit better than drawing by hand. This is one of the classical papers on the MAC reduction of remifentanil when given the combination of isoflurane and remifentanil, and you see that there is a MAC sparing effect of remifentanil on isoflurane, and you clearly see that there is a synergistic interaction between these two drugs on the end point here, and this was the S is a success, no response to skin incision, or F is a failure when the patient moved on skin incision. This is another example of a straightforward approach to study drug interaction using the isobolographic approach. This is from Peter Siebel's group from Atlanta. And what they did is they studied one situation where they looked for a loss of consciousness. This was their endpoint, loss of consciousness when giving propofol alone. That's here, when giving sevoflurane alone, and when giving the combination of both at the 50% level. And you see that this is the line of additivity and the confidence interval, and it's just it stays in the area of the additivity at the 50% level. With this kind of isobolographic approach, and this is a classical approach that you will find in the clinical pharmacology literature most commonly. This is very classical. You just study the 50% approach, and this is done with the Dixon's up and down titration technique, this study. And of course, this only gives you a very fractional idea of your interaction, because it's only at the 50% level. Now, as I already said, 50% is for perhaps for clinical pharmacologists a good set point, but not for us as anesthesiologists. I don't want that half of my patients are not getting the right therapy. I think I will not be a board-certified anesthesiologist for a long time. I want to be at least at the 95 to the 99% level, so I need more. Another approach, combining isobolographic approaches with something more, was the study from Jaap Fuik, and in fact it's a Stanford study because Jaap was doing his fellowship at Stanford University at that moment. And this is one of the largest studies studying the interaction of propofol and alfentanil. Their endpoint was what they called an accurate level of anesthesia, whatever that might be, because later on I will show you that in literature now we found enough evidence that accurate anesthesia is not one thing. It's a continuum of I think two universa, being the hypnotic one and the analgesia one. But you have to put all these studies, as always, in an historical concept. So it was great for starters, and the propofol and alfentanil interaction isobol from Jaap Fuik's study clearly shows that on all the endpoints they studied, you have a synergistic interaction, both for intubation, for maintenance, and for emergency. Now, as I said, and that was also what Jaap did, next to the 50% isobol, he studied the complete surface. And as you all know, the isobol here is only one slice of the complete interaction surface. And as Talmadge and Steve a while ago wrote an editorial on, we are in California, so you have to surf the wave of the 95% isobol, which is up here. And this is the interesting point. And for us as clinical pharmacologists, it's of course nice to have an idea about the complete surface of interactions, because why should the interaction here be the same interaction as over there? You have to study this. Now, question, how to improve the changes? So the structural mathematical model fits that 3D response surface in such a way that it will represent the underlying pharmacokinetic dynamic reality within that studied population. Therefore, we need that mathematical model, and that's in fact the title of my talk. Well, first of all, you need data, as I told you, and you need to optimize your strategy, your methodology, when you study these data, and that's not that easy. First of all, you need the right sample size. You have to ask yourself, as the investigator, how many observations do you need per subject? One or multiple? And you have to randomize the pharmacological condition within the population, as was shown by Tim Short's group in 2002 in anesthesiology, and this is some details of that study. When you combine the two drugs, the concentration of the two drugs or the dosages of the two drugs to study the interaction, it's, as proven by Tim Short, it is quite important how your design of your study is done. And they studied with an existing data set, they studied a slice approach, so they only studied one direction, or you do what is called the crisscross approach, where you crisscross, not at random, but in a well-orientated way over the surface, or you do what is called the radial trial approach. So these are the three approaches in the combination of the drug concentrations that you need to do to have enough information to fit your data to a specific surface. I will skip this one. These are some results of that study. And this is a three-dimensional concentration response graph of the three approaches, and this is the worst fit. And you clearly see that you have some bulging problem here. This fits quite nice at the surface, and here you have a problem over there too. And here it doesn't come to the maximum effect. So in Tim's paper, also mathematically, he could prove that this approach, being the crisscross approach, is the best approach. And that's what he wrote in his conclusions, giving certain assumptions. He said the crisscross design is the most robust result using the least number of patients or volunteers. So when you do this kind of drug interaction study, I think it's appropriate to use the crisscross design. And in fact, in one of the studies our collaborative group did, and that was published in 2009 in Anesthesiology, studying the interaction between Propofol and Sevoflurane, we did this crisscross approach. In 50% of the patients, we kept the Propofol effect site concentration stable, and then we did a step up of Sevoflurane, and then in the other 50%, we did the other part of the crisscross where the concentration of Sevoflurane was kept stable. We equilibrated everything for more than 15 minutes, and then you do a step up in the other way. And then when you combine all these data, you will get a good idea of what you need to build your database. Now, answer 2 to this question. Now we have the data. We did it in the right way. We used the crisscross design. Where answer 2 is now you have to use the best mathematical model. Should you use the Greco model? Which models are available? Greco was the first one, but I will show you that there are some other models available. Are there differences, or are all these model approaches the same? And what fits best? Now, this is something I assume you all know. This is the basic concentration versus response relationship, showing you the relationship between a specific receptor or effect site drug concentration and the probability of having no response. And of course, it makes sense if you give more drug, the probability of having no response increases. You need 4 parameters to describe this Emax model or sigmoidal curve. That's a bottom E0, Emax. This is quite an interesting point to have, which is the concentrations where 50% of your population will have no response anymore, called the CE50. And of course, you need the gamma being the slope of that curve. Keep that in mind. And now we start with 10 minutes of hardcore mathematics. I apologize for that, but we need to do it. Because there are some models in the literature. You have the Greco model, you have the modified Greco model, you have the Minto model, you have the hierarchical model, and you have the modified hierarchical model. All right. When you start as a pharmacometrician building a surface on the data you have, I think it's quite important that you try all these models. And it takes time, but you have to do it because there are some differences, as I will show you, among these models. And you should really do it. And I see in the literature, unfortunately, that some groups didn't explore, and we are guilty too. In our older work, we used the model we thought was the best. But we learned from our newer studies that it really makes sense to look to the different modeling approaches and run them through non-MEM or any other statistical package that you use. And you will see that